part of the PCN DES, you now need to look at the standardisation of GP appointments. This is part of both the DES and the contract itself. We'll be talking about what you need to know about this new change that's coming through, the contractual requirements of what you have to do, and what it all means, because it can be a little bit confusing. But don't worry, I'm going to explain it all for you right now. Let's tech enhance your primary care and learning. If this is the first time we're meeting, I'm Dr. Gandalf of GP Learning, where I look at supporting you with technology-enhanced primary care and learning. And in this episode, I'm going to review the GP Standardisation of Appointments document released by NHS England as part of the GP contract and how this relates to you, your practice, your network, and basically the work you need to do over the next few months in particular, because this is really important. You have to do some of this by the end of June 2021. We're going to be having a look at the document itself, and I'll be going through the various different aspects of it and what you need to know and hopefully not know about it, and go through every single type of appointment that you need to consider when it comes to this. Yeah, I know. Seems a bit intimidating, doesn't it? Don't worry. We'll explain it all nice and clearly for you. Let's get cracking, shall we? So if you want to check out the document itself, have a look. The links are going to be down in the show notes for you. And when you do get to it, you'll get to basically this, Network Contract Direct Enhanced Service, Standardization of GP Appointment Categories document. It's a little bit long, 38 pages, but there's lots of good content and details and guides to help you understand this principle. It's important to note that this is part of the GP contract that's been introduced and negotiated with the BMA and the GPC itself to help understand how we categorize our workload. That's the focus of this particular work. The reason why it's included in the PCN DES in particular is A, to try and encourage us to do it, but also it is linked with the IIF payments in terms of how we do this. So that's the Impact Investment Fund. So there are 27 points, I believe, that's available for you if you use this particular thing. And you have to do this by the end of June to get those payments. It's a binary thing. You either do it or you don't. And if you do it, you get the payments. If you don't, you don't. What does that mean in terms of actual payments for the network? We're considering £1,200. That's just over £4,000 for each network. This has been extensively negotiated, so hopefully this information should most people be aware of. There was a really big consultation a few months back about it. And the preamble, well, you can read it if you want to, but it just basically explains everything that I've just mentioned. It's really important that you're aware of the various different reasons why this might be happening. It's basically a mapping exercise. So what that means is obviously every practice has within its own appointment book, the screens that you use, whether that's an EMIS, System 1 Vision, whatever, the various different types of appointments you have. And rather than making every practice change all of their appointments to a particular appointment type and causing absolute chaos if they did that, simply put, you just need to map your existing appointments to one of the 26 different types of appointments that are now available. And then that information can then be reconciled by NHS England, NHS Digital to understand the type of workload that we have. That sounds sensible, doesn't it, in some ways? Because then that means we can actually start to capture the workload that we're actually doing and show people how busy we actually are. That's my view anyway. In terms of support, so they do outline the various different pieces of support that will be made available. So apparently each area will have a local champion user. I'm guessing someone might be knocking on my door to do this, but yeah, not going to happen, I'm afraid. This is my contribution to the efforts. Alternately, there are going to be some system-specific guidance. So from System 1, EMIS, Vision, I'm sure there'll be different information coming through. And some of you may have already seen some of these changes happen in the background. There will apparently be some series of webinars. I've not seen any dates for these just yet, but clearly if these are available, let me know. I'm more than happy to put them in the show notes and stuff so people can access them. And some FAQ documents will be coming out shortly. And I hope shortly, because we don't have long for the first deadline. And the reason why I say that, as I said, the Impact Investment Fund, the first deadline is the end of June that you've got to get the initial work, the mapping exercise, which is not the hardest thing to do, but we'll talk about that in a second. The key thing is important to remember that it talks about appointments and the definition of appointments themselves in the document. So at 1.8, it talks about the various different types and guidance that exist to help it understand what an actual appointment is. In terms of the categories, so it puts them into various different categories, which there's 4 types. So there's one, what those happening in general practice itself. The 2 is those happening in the PCN, so PCN staff delivered effectively. 3 is extended access provision, so those extra hours we're providing outside of our contracted hours as part of the whole DES workup as well. And then they've given us a category of other, which is quite nice because then we can stick extra things in there which may not be applicable. And it'd be interesting to know where people are going to put various different things in there. It then splits into 3 different types of categories. So you've got care-related encounter. So this is basically direct patient involvement-based encounters that you have. So, this obviously can be your face-to-face consultations with the patient, telephone consultations with the patient, various different things like that, home visits, online consultations, they all count, group consultations as well. Then you've got care related activities. So this is stuff like your clinical admin, all the various different stuff that you're doing with the patient itself. So, for example, processing their prescriptions, med threes, various aspects along those. And then you've got administrative practice and staff activities. So this is other kind of stuff that doesn't specifically involve a clinician to have a contact with. So this could be the actual processing of the prescriptions. So obviously, there's the prescribing act that we as GPs and pharmacists, etc., may be doing, but then there's the actual handling of the prescription requests, which our admin teams will do. So that would be an administrative stuff. Your practice meetings, breaks are included in there. So there's good quality stuff to have a look at, and understanding how they split into the three different categories, I think, is really useful. It is commented that practices are not expected to itemize the parts about the care-related activities, so the non-direct patient-facing stuff and the administrative stuff in your actual appointment. So you don't need to put down an appointment slot for each patient that you've then done a prescription for example, when you haven't actually had an encounter with a patient. However, if you have had a clinical encounter with a patient, then that should be registered on your appointment book to count the actual number of contacts that are happening. We'll go through that in a little bit more detail when we look at the 26 different appointment types. It's important that we won't actually be using the other parts to measure and stuff with, so the care-related the care-related activities and the administrative stuff, but it's just there so that practices have something to reconcile and so it can give some information on the terms of workload. I think when you're trying to structure your clinics, this may help to basically enable you as a practice to understand what people are doing, when they're doing, and that kind of stuff. So we're going to get started off with the actual appointment types themselves. So first category is this blue kind of category, and it's the care-related encounters. So this is the ones that involve patient contact. And the first one you've got is your general consultation acute. So this is probably where majority of our initial boatload of work has come from. So this is, your urgent appointments. These are emergency stuff, one encounters, that kind of thing. And these are, contact on the day, demand-led kind of encounters that you have. Very clear, this is separate to clinical triage. We'll get to that category later. There is a separate one for clinical triage, but this is the face-to-face. This is the various different work that you do in practice that's acute clinical demand. You then got general consultation routine. So this is kind of what most people would see as their standard GP appointment, the one that patient may have booked in previously, routine kind of encounters, chronic disease reviews kind of stuff and things. But that's separate to your actual long-term conditions clinic, and we'll get to that in a second. But basically the activity that you would have known about in advance. So I'd be interested to know whether the shift of the pandemic has changed the way we do things in terms of how this works for many practices. But this would be typically the stuff that the patient books 2 or 3 weeks in advance as part of their potential review, or that kind of stuff. We then get to planned clinics. So as I mentioned earlier, you've got your long-term clinics, so your asthma clinics, your diabetes clinics, your antenatal clinics, your child stuff and all that kind of thing, or your kind of planned clinics that you would normally have. That comes into this category. And then we talk about your planned clinical procedures. So that's slightly different to your planned clinic. So this is more specifically on things like your minor surgeries clinics and things versus your vaccination clinics, or those actual interventions where you're doing something with the patient. And they've got additional stuff in there. So spirometry, which obviously at the moment we're not doing a huge amount of. Smears definitely is incorporated into that. I'd be curious to know where things like, if you're bringing a patient down for an Epley's maneuver, may fit into this, or some of the more specialist stuff like dermoscopy and that kind of thing. I personally think it may fit into this particular part. Be interesting to know what other people think and see what the webinar information shows in some of these aspects and things. Then you've got your unplanned clinical activity. Now, this I think is going to be a hard one to distinguish between the earlier one, the general consultation acute that we saw. But the difference that I can understand from this is, so your general consultation acute is your on-the-day demand that you would normally have. So, for example, if you've got a salaried GP's clinic, they would have a proportion of that which is on-the-day acute demand, whereas the unplanned clinical activity are the extra ones you've stuck in your on-call GP, the extra number that you've had to see because there have been 1,000 people on the triage list and stuff, so therefore you have to see more patients, the squeeze-in appointment. That's how I understand it. And then they have category 6, which is your walk-in. So many practices I know are still doing things like walk-in clinics, whether that's for nurses, GPs, that kind of stuff. If you've got a specific one where the patient doesn't have to have a pre-booked appointment or doesn't have to be booked in, they literally just walk in, then that's the category type that you have for this. Next up, we've got clinical triage. So I mentioned earlier that clinical triage is a separate category of appointment type. And this one's really interesting because I think many people are probably doing this right now with the total triage shift that we've seen. And it's important to note that this has to be done by clinical health professionals. So this can't be done by your admin teams, although I really would not recommend that's being done. But in terms of then figuring out where this sits in your kind of appointment rota and stuff, that's important to note. And we come to about the usability of the appointments, which comes later. It's really important you stick around for that because that's key information. But in terms of how this works within your clinics. So this, I think, is probably where a lot of people are going to find a bit more trickiness, because you may obviously have patients that are then triaged that then converted into a face-to-face, and that may not be with the same clinician. How's that going to work in terms of accountancy? Well, that's why you need to be booking these patients in individually for each of these slots, not just using the same slot for the various different contacts that you've got. Interesting changes for some people in some practices they're going to have to make with this particular one. Next up, we've got home visits. So there's two different types of home visit categories. There's one for the general kind of home visit that you may be doing, whether that's going out to visit a patient for the COVID vaccinations, dementia reviews, basically anything that's not taken place in the practice itself. That is different to a care home visit. So you do need to specify the different type of visits that you're doing. So you need to potentially have one different list for, one appointment type for care home visits, one different appointment type for visits. I'd be interested to know how this works on System 1, where there'll be a picker system that allows us to identify which one is a care home visit. Because actually, for example, on the system I use, System 1, there's just a section for visits. It doesn't really specify which one's different, so I'll be keen to see how that's distinguished by the system providers for each of the different areas and things. Next up, we've got group consultations. That's category number 10, and group education events. So this will be things like, lifestyle awareness, smoking cessation, all that kind of stuff. Shared appointments effectively. And it doesn't distinguish whether this is video-based group consultation or whether this is in-person-based group consultation-based. Now, this may be clearly something that's supported by PCN staff. This could be done within the practice and things. It's important to recognise that aspect. After this, section number 11, we've got structured medication reviews. So it's important to recognise that particularly your pharmacist-based reviews, where you're doing the structured medication ones, you've got specific appointment types that are dedicated for this. This is a massive part of the DES itself and a requirement that you have to do, and they will be tracking the numbers that you're doing. Yes, it's based on the provision of pharmacists you have this year. That may change in the due course, so make sure you get this right, really important. So your PCN pharmacists that provide for you, they're doing structured medication reviews, make sure they've got the right appointment category for that particular part for themselves. Then we've got patient contact during a care home round. So many practices are now doing the regular weekly care home round. This is the appointment slot for that. This is, that contact that you're having. That doesn't necessarily mean you've gone out to visit them. You may have done, but obviously some practices are doing these remotely or alternating between remote and in person, for example. So this is the allocation for that particular work that you're doing. And then there's a separate one for the care home needs assessments and personalised care and support planning. I'm having to read that one because it's so long and stuff. And this is the more detailed kind of needs assessment that may potentially happen. This may be done by your practice, may be done by other providers, potentially, depending on how you've structured that system within your area. So it's important to recognise that. Section 14. So these are more PCN-based ones, as you can figure out. It's the social prescribing service. So the contacts that your social link workers are having within the patients and things. Again, I think this is to pick out that particular metric for the centre. And then you've got service provided by an organisation external to the practice. So this can be a variety of different things. This can be community-based clinics happening within your practice. This obviously does happen in various different areas. Geriatricians, psychiatrists, Macmillan nurses are some of the examples they've given, including the Citizens Advice Bureau. So I know some practices where obviously they have finance advisors come in to help patients and things. But the key thing, this is a service not provided directly by the practice, but housed within the practice environment. I think this is nice to capture this kind of information, because I know there are definitely going to be some practices where their estates management is based on this, and how that will look. Really interesting part, I think, for us to consider. Next up, we've got to section 16. So this is non-contractual chargeable work. HG medicals, all those kind of stuff, taxi drivers, research, all that kind of thing. That needs to be captured in some way, and that's what they're asking us to do here. And then next up, we've got this care-related encounter, but it doesn't fit into any category. So if you do happen to find something that doesn't work into any of these potential 17 categories for your care-related stuff, you stick it in here. I'll be honest, I can't really think of much that would fit in here. If you have done so, stick it in the comments and let me know. I'd really like to know if someone's come up with something that doesn't fit with these criteria. And we've got a system to help you understand that in a bit coming up. However, next up, we've got the care-related activities. So this is the kind of like clinical admin-y kind of stuff. And the first category is patient clinical admin. So this is things like your medical reports, your insurance reports, all those kind of stuff that you're doing, and absolutely prescriptions and fit notes fit into this category. Interesting that they don't feel this is counted, and obviously what happens to the consult that you have with a patient where they end up booking an appointment, it's all about their fit note or it's all about their repeat prescriptions. Well, you've had a contact with the patient, so actually it goes into the earlier ones of planned or acute clinic, depending on which one you've done. But if you have a particular part of your day where literally you're just going through your repeat prescriptions, or you're just sorting out med threes, or just doing your insurance reports and stuff, capturing the amount of time that you're doing this, really useful. And do you have structured and separate time to do this? I think for salary GPs, this is going to be an absolute requirement because most practices probably have done this. The interesting part and the challenge I think many practices are going to have with this one is partners, because we just squidge it in, to be honest. So creating a structured template of what your appointments look like within your practice for your partners, I think that's going to have a real challenge for the second part of this workload, which is the August deadline of having this work done by then. So yeah, we're going to see this one be a real fun one, and that's where I'm looking forward to the webinars to help give us some guidance on how this works, and also the system providers in terms of TPP, EMIS, that kind of stuff, how they're going to help us understand how that flexes. Number 19 is multidisciplinary team working and patient meetings and collaborations and stuff. So this is your, audits, your adult safeguarding meetings, your child safeguarding meetings, palliative care work, MDTs, that kind of stuff. Really important that we do these. I think they have real benefits. And obviously capturing the amount of time we're having to spend on these, I think is really important and useful. And then they've got care-related activity that doesn't fit into something else. So, if it doesn't fit into one of those two categories, what it may be. Again, tell me if you figure out something that doesn't fit into those two categories. Now, the last section we've got, and the last kind of 5 of these is around administrative and practice staff activities. So the first two, 21 and 22, are interesting because these are about supervision and mentoring, and they're from 2 different parts. So there's the person providing the supervision and mentoring and training, and then there's the second part of the person receiving the training, supervision, and mentoring. And it's important you remember you're going to have 2 different parts to this. So I know, for example, in our practice, we've got the same kind of appointment slot for when I do a tutorial with my GP trainees. What's interesting for this is we're going to have to separate those out. So we're going to have one for the person who's delivering the training, and the second one for the person who's receiving it. And that is a change we're going to have to make in practice to capture the different appointment types, because it is slightly different. It's a minor change, but it's something to be aware of. Next up, we've got business and management activities within the practice. These are your practice-based meetings, your partner-based meetings, other kind of stuff. If you've got QOF meetings, let's focus more around how you do things in practice rather than direct patient care. Seems quite sensible and appropriate and things, but obviously not booking patients into that particular part. And then you've got one for clinical housekeeping and admin, which I can see many people figure out this takes up a lot of stuff, but actually it's more around the running of the practice itself. So it mentions things like fridge checkers, COVID check and control, all that kind of stuff, cleaning the rooms, drug checks, and that kind of stuff. I guess this is done obviously more by your admin team and things, so focusing on those particular areas. Again, no appointments should be used for this. And then the last 2, breaks and staff absences. So really interesting that they want us to capture our breaks. Don't know how that works. I don't think I ever get breaks sometimes. So yeah, it'd be interesting to see how that works. But clearly, for employee staff, having dedicated break times captured on their appointment slots would be a useful way for looking at job plans. How that work roles in practice and stuff. Basically, just capturing it. NHS and I don't think are really interested in this particular data, but I think for practices, this will be a useful way of showing how they're working in practice. And then, again, we've got a category for something that doesn't quite fit into any of those ones that we've already discussed and things. Interested, again, to know what that might be, but hey, we'll find something, I'm sure. And if you have found any of the unknown kind of categories, like I said, stick a comment down below. Now, just before we go through the flowcharts and the key pieces of information you do need to know about some of the usability of the clinics, if you have found this useful so far, definitely leave a like down below. Lets me know this is useful content for yourself, and really would appreciate your comments on this part. So the next few pages are basically a flowchart to help you understand how to fulfill the various different types of appointments and where you put yours that you've got. So for example, look at my practice. I think we've got over 60 different appointment types for various different things. And we now have to match each of those to one of these 26 types. To help you do that is this flowchart. So you start off in what is the setting. So is it GP or private work? Is it PCN contract? Is it extended slot? Or is it an unspecified one? And basically, if it's a yes, they will go to B anyway. So I'm not quite sure why they've done that, because they all take you to B. But yeah, those are the ones that you need to capture. I think the key thing for this is if it's none of those, you don't need to jot it down, which, again, I don't quite get that first part. The key part is actually the B section, the context type. So this helps you figure out which particular appointments are. So is this related to a patient encounter? C. If it's not, then is this slot related to a patient encounter, patient care without an encounter? So when you're not got the patient in front of you, you go to D, and then is this administrative? Then it goes to E. In terms of D, this then helps you split down, going through the flowchart, what the different types are. So we mentioned, obviously, routine appointments, got the acute appointments, gives you the numbers next to them, and it helps you understand where to fit these kind of things in. Similarly, for the categories for clinical encounters, and then you've got the practice admin ones as well. You just need to follow the flowchart, to be honest, and hopefully this should get you through most of your appointments. If not, well, they give you some case examples that you can have a look at. It does mention about default slots and things. So, they recommend that you don't use default slots for all your appointment types, because actually it's not going to capture any useful information in the longer term. And we're looking at moving towards using these different types. And that's one of the reasons why many of you have probably seen from now onwards that when you try and put an appointment in, it mandates that you have to put one of these 26 types next up to it. So I mentioned there's this concept of surplus appointments, and this is one thing that I think is going to be an active change many practices are going to have to do when it comes to the appointment books that they have. And this is in relating to understanding the actual amount of work that we're delivering. Because annoyingly, this looks like it's going to be a calculation that's made without our involvement. And if you get it wrong, it can really inappropriately reflect the workload that we have. So it talks about unused and surplus appointments. So unused appointments are appointments within a structured planned clinic that aren't taken. So, for example, you have a GP's clinic. They've got 20 slots, for example. I'm just picking numbers out of the air here. And 2 of those are not used because they're not booked in. Okay. So on the basis of that, and we're going to squidge down. So we've got the example. Here we are. 20, 18, 2 not used. That means we've got 90% utilization. Okay. That's not bad. I'd say most of my clinics are about 120, 130% at the moment. But hey, that's the example they've given us. That's different to surplus appointments. So these are the types of clinics where you don't actually know how many patients you would have. So a great example of this would be our triage list that many of us have probably got. So if you've got a specific list where everyone's picking off patients from a triage list, that is potentially going to have a surplus, because you may create, for example, 50 slots and only 30 people end up calling in that particular morning, and therefore you've got an unused amount of slots. So that's your surplus. So it goes. So there's an example is 40, 20 are used, and therefore you've got 20 unfilled, and that gives a utilization of 50%. And the problem with that is then that may then come across that you've only done 50% of your workload to the powers that be when they look at the information. So the key thing is, for those triage-based clinics, for those slots where you just have loads of slots to counter how many people may actually turn up, you then delete or get rid of the surplus ones to incorporate the fact that you've actually done the whole utilization. That's a really important step I think practice is going to need to actively do on a daily basis, because otherwise you potentially could be saying you're doing half the work that you would not, the utilization is not great, and that affects the data. And you know what? Some of these reports of GPs being empty, all that kind of stuff, you can definitely see how various different media outlets may use that data in the future. So, important to recognize that part. The next section gives you various different details of the various different ways you can put put appointments into these various different categories. So it talks about a pre-booked flu clinic. So this is a general practice setting, and the context is related encounter, and the category is a clinical procedure. So this GP category 4, the modality is face-to-face, and then you put the duration and how long that would normally be, whether that be a 5-minute slot or 10-minute slot, for example. That's how you do the category. You've got various other kind of ones as well that you can look at. So nursing long-term conditions, got GP phone triage. So let's have a look at that one, really common one. So the service setting is general practice. You've got context is a care-related encounter, and the category is clinical triage. So it's GP category 7. The modality can be anything from telephone to online or something else potentially. Well, the phone in this situation and things. So it gives you some really good examples to help understand some of the basic kind of ones you may want to consider. Now, I'm aware loads of people say, well, I've got one that says 2-week wait slot, or I don't know, I'm just picking names out of the hat. But, work through this with your practice. It may even be that you want to work through this with your network to kind of get some benchmarking and that kind of stuff from other practice to see what people think about. It does have a dedicated section to look at online consultations, so the slot plans and that kind of stuff that you have, and it gives you a good idea of what kind of consultation you have. It's an interesting part, and it's trying to help you understand the definition of an appointment versus not an appointment. And I guess this is the key thing, that if there's a clinician involved in contacting and negotiating with that patient, that's an appointment, and therefore it's a care related. I've forgotten the terms already. Care related encounter. That's it. Compared to if it's one of your admin team moving slots around or that kind of stuff, or your admin team signposting patients to other parts of the system, that's not a care related encounter. That's the workflow of the practice itself, and that's more a care related activity. So that's the other kind of groups. And that would be something like category practice admin, category 25, for example, they've put down for that. So it's important to recognize that key difference of its involvement with the direct contact with the patient, whether that's through an online route, a telephone route, a video route, a face-to-face route, or a visit route and stuff. So important to recognize that part and things. And then finally, it talks about secure messaging processing. Again, the last kind of, it's a similar process, basically. It's based on whether or not you've got an encounter with a patient. There is an extra session put in there about COVID vaccinations, and particularly if people are having other centres being able to book into your COVID vaccinations. Just read the document. It's pretty self-explanatory how to do that, and it recognises that there's some parts that are not within your control. So hopefully that guide has helped you to understand the various different types of appointments that exist and how you need to categorize them within your practice. Just to go over those kind of deadlines. So by the end of June, you need to have done the actual matching or mapping exercise, and hopefully there'll be more details and kind of support coming to your local area to explain that with the webinars and everything. And then by August, actually, you need to be having this structured within your practice as to how it looks. So this may involve some significant changes to the way that your appointment book looks and runs, and how your practice potentially even runs. I know some practices where this is going to be a significant amount of change for them in terms of how they capture their patient encounters. I think it's really important that you are trying to capture those patient encounters. So, for example, those on-call ones in particular, where a patient just rings up and you do something, you document it, and it's done, but you may not have actually put it down as an appointment slot in your appointment book. You now need to. That's the key thing, because that's uncaptured workload data that if we don't start capturing that, then may feed into this whole thing that GPs aren't busy, when we know absolutely GPs are critically busy, into the point where, well, we're overloaded. So hopefully this has been a useful guide to many of you to understand these various different aspects and stuff. Definitely leave a comment down below and a like if you found this episode useful. If you want to check out our episode that goes about the PCN DES and the IF funds, check out this video right here. Alternatively, YouTube's probably recommend another video for you right here. And as always, eGP Learning is here to help save you and your patients time by taking answer in primary care and learning. Catch you in the next episode.